Okay, we're going to do something unique. Who was the first person to raise his hand? Somewhere over here. Are you in the same place that you were? Just don't be afraid, don't be ashamed. I mean, we're here to discuss things between ourselves. First of all, I have to thank the people that are willing to share their paper with us. It's not an easy thing to receive criticisms. So we decided that instead of me giving a talk, no formal talk about critical appraisal, we will go through the critical appraisal as we go along and critically appraise this paper, which would be, I think, much more instructive.
I just wanted to say this is I'm just reviewing it. It was even it didn't go to anywhere, and it wasn't review. I'm Brazilian. I'm not a native English speaker, so it might have some errors of the English also that I'm gonna send to an English reviewer before submitting to anywhere.
But I would recommend that you take a piece of paper and you note down the comments that we come across with. That would help before you go to an English-speaking writer. Now, we did talk about this morning, and I just want to make a further comment on ghostwriters. Everybody was here when we talked about ghostwriters? No? You know what a ghostwriter is? A ghostwriter is somebody that you hire. Just go on the web, there's thousands of them, thousands, that are willing per payment to write your scientific paper. Some of these people are very good, some of them are very poor, and even for the good ones, you have to revise, you have to go back and make sure that there's no medical problems. The only thing that what happens is they know how to write, but they do not know how to write medical papers. One. Second of all, there are so many particular aspects of our profession, our surgical profession in particular, that the misunderstanding is very, very easy to come, even though they're proficient in English. So the English is one problem, the contents is another, and it's most important. Okay?
If I can make a comment, there are two different kind of these systems. Ghostwriter. There are some that actually really get into the details of your work, and they may create problems. There is also another group of people that just check your English, if it's correct in the sentence and in the grammar. And these are probably more important for not English-speaking, mother tongue authors. Surgical endoscopy has a link. It doesn't have any financial relationship with them, but they can suggest you where to send it, but they will only correct your English, your spelling. And this is, I think, is very good, especially because if you do it, and then they criticize your spelling or your English, you can say, well, I went to the person that actually you suggest. Right. So, and the price-wise, actually quite reasonable. They're not too expensive. The ghostwriter itself is actually somebody that you really give, your data, and you say, okay, well, write down the paper for me. Right. And this, I think, is incorrect. I mean, this is something that may lead to major misunderstanding of the result of your research, because that's our dangers. They do not have to change anything of the meaning of the paper. But I agree with you that you need to always revise.
You always have to revise it. I think it's wise to always revise. Okay, so you have the paper on the screen. I see a title. I do not see an abstract. You have not written it yet?
It's not written yet.
That's good. Remember, we said
point.
Abstract and title should go at the very end. So let's just read the title to make sure that, let's see what the impression is, okay? Read the title to yourselves.
There are two titles, two possibilities of titles. There are
where is the second title? Oh, okay.
On top and one behind. Yeah.
So, yeah, everybody understood that there's two titles. One, is that the preferred title?
Yeah.
All right,
The
okay.
preferred is underlined.
That's not correct. There's one or two spelling errors. That's not a problem.
Yep.
Does everybody get the gist of what that title is going to be? What the paper should be according to that title? Prognostic factors. It seems pretty clear, straightforward. Prognostic factors of surgical treatment in patients with distal rectal cancer. Colin, a 10 years experience of a single university institution. Anybody have any comments of just how? Hi, Patricia.
Hi, Patricia.
Hi. Good to see you both.
Come here. Oh, I see. Okay.
Please use the mic so that everybody can hear.
It does not tell us what is the relationship of the prognostic factors to surgical treatment, whether the relationship is for choosing the right treatment or whether the relationship is finding out outcomes of the surgical treatment. So they are really not telling us the relationship.
Okay, I take that comment, but I think there's something more, not troublesome, but something ambiguous. Anybody have an idea or a comment on that? Let me ask the question to the author or the co-author. What do you mean by a prognostic factor of the treatment as opposed to the disease? Is it prognostic factors for the success of the surgical treatment? Or?
Because in this, when we go through, we're going to have two possibilities of treatment: the LAR, the low anterior resection.
No, wait a minute. This always happens when we do this sort of thing. And it's it's very important. I ask a question, and he's explaining the whole study. Okay? This is the problem with medical writing. You know the topic from A to Z, but you have a specific task, that is to answer my question. I'm not being critical, overcritical, I'm hoping. But that's the exact exercise that I'm looking at, because I want to know what you mean by those 5 words. And I want you to explain it in one sentence.
It's the prognostic factor of the treatment I apply to the patient. Is how the patient is gonna, what's the outcome is gonna be of this treatment.
Okay, so it is related to the treatment rather than to the disease.
Yeah.
Okay, then the title
the
for
the
the time being, it looks okay. Any other? Options? Are there different techniques that you have used?
Yeah.
Yes?
Yeah, I think the one below says surgical treatment strategy. That's sort of an option. I don't know if the title below would be better explained.
What's good about the first title? The first title, remember we talked about we have to have a notion of the population. We have it here?
Yeah.
Everybody okay? We have to have a notion of what kind of a study it is. Not really, but it's a 10 years experience. Okay, so it's more or less there. We have to have the notion of where, I'm sorry, the third one was where it was conducted. We have it. And then the fourth one was the actual topic and that we're going to work on. Okay, let me put, yes?
Yeah, I just want to know, because I haven't read the paper, so what are you trying to prove? What is the best surgical treatment according to some factors, patient factors? That is the purpose of the study.
Yeah.
So, because I would personally say, you need to describe that you want, this paper is going to tell you have different strategies, you have different surgical approach. What are the factors that influence your choice? Is it correct?
Yeah.
So I think the title is not explaining that, because it will not tell me, okay, this is a paper where the author presents a different strategy for distal rectal cancer. Which one is the best according to the prognostic factor of the patient? Is it correct? I think it should be rephrased, because prognostic factor is a factor related to the patient, not to the surgical treatment. So you want to say, okay, I would maybe rephrase a ideal surgical treatment for distal rectal cancer. Prognostic factors is something that will explain that the prognostic factor will influence the surgical treatment.
I agree. I agree with you, Luigi. Let me suggest that we start reading. Yeah, you want to say something? It is much more descriptive, but we're missing the single university institution and 10 years experience, which were good things. He could put that as a subtitle. Huh? Would everybody agree with that? Yeah. But I think I agree. The second title is more smoother, and but we don't have the word prognostic factor, but outcomes. Maybe you should say prognostic factors. Prognostic factors intervening in the choice of surgical treatment or something like that. Let's just keep that in mind and walk on. Yes, please.
Maybe we could say that prognostic factors as determinants of surgical treatment, or prognostic factors as determinants of surgical strategy in patients with distal rectal cancer. If that's what he means.
Sorry, say that again.
Prognostic factors as determinants of choosing surgical treatment.
We're still looking at a title that's fairly long, okay? Probably too long. I would suggest that we move on and keep all those words and try to permute them. What's the most important? Remember what I said about a title? The first words are the most important words. The problem with the second title is the first word is patients with distal cancer, distal rectal cancer. That should not be the focus words, I don't think. I don't know if anybody agrees or disagrees. That's what I asked. The first question is the prognostic factors, or the prognostic determination, whatever you want to call it, for the best option, surgical option. So once again, this should be the key words, the strong words, the focus-centered words have to be the first words of a title.
If we take out patients in the second title and say distal rectal cancer outcomes or prognostic factors associated to surgical strategy, something like that.
What about something like surgical treatment or choosing the best surgical treatment for patients with distal rectal cancer? The permutation is something important here. This is what's important. I'm sorry. This is what is important. It's the strategy, right? The prognostic factors or whatever, and the strategy. These have to be the first words of your title somehow. Anybody agree or disagree? Yeah. Okay, good. Okay, let's read the. Well, we can read the introduction. Okay. I'm going to let you read it by yourselves. The only thing is that we have to scroll up. Wait a minute. Well, if you can scroll, can you scroll a little bit?
You can do it.
So that we have the whole introduction. Perfect. No, we don't have the whole introduction.
No, I think the first part, yeah.
Yeah. Okay, so let's read the first few lines of the introduction. You don't want me to read it out loud, no?
I have a comment of these few lines.
Okay, what is your...
My main comment is that your article is on distal rectal cancer. This is a completely different disease from colon cancer. So all the comment that you made in the introduction about colorectal cancer, they're mixing up, colon and rectal cancer. I think that is redundant. This is a very common mistake that I see. You talk about a topic, but then you give data. That is okay, but is is useless because you talk about colorectal. So I will make details on rectal cancer and then focusing on distal rectal cancer. That is, you can't put it together because the incidence of colorectal cancer is not the incidence of rectal cancer. And also the improvement that we have for rectal cancer is different improvement that we have for colorectal cancer.
I would agree.
Incidence, though, there's nothing wrong with introducing the incidence of colorectal cancer. Most incidences are unique in general for colon and rectal combined. It's hard to get you guys specific to a country about incidence of rectal. So I don't have a problem with your introduction just talking about incidence of colorectal cancer in general before you narrow it down to rectal cancer.
Well,
Let's see if he does that.
let's see if he does that.
Okay, let's see if he does it.
That's what we thought. That's what we would situate the reader about colorectal cancer. We don't have an incidence specifically for rectal cancer in Brazil, so I think that's why we put the general colorectal cancer, and
But
then
no,
we
you do
straight
say-
it to rectal cancer. That it's 30% overall. Like it's proximate, not.
Okay, let's go back to, you've given the incidence, okay, here. Okay, everybody agreed it's an incidence and not a prevalence? Anybody think it's a prevalence? Why is it an incidence? For the year 2016, exact, okay? He does give that for colorectal cancer, and then he says rectal cancer is approximately 30% of that population. So he is giving some way the 30%, if we can say that the incidence, let's say, if we assume that 30% is irrespective of what year it's being performed, which is not probably true because reference 3 might be from, what is reference 3 from? Do you have an idea? Can you?
I think it's.
Can we scroll down to reference 3?
Reference 3.
Because if reference 3 is from 1935,
I can get my computer.
Oh, I can do it?
Yeah.
No.
Oh, okay.
Do you want me to get computer? I don't remember. I think it's.
Can you scroll
it's
down to the
Inca. It's
all
an
the way down?
institution of colorectal cancer in Brazil that does this. Of colorectal cancer, no, of every cancer in Brazil that does this statistics.
All right.
I think
Can-
it might
Can you
be.
scroll down to reference 3 so that we see reference 3? Sir? Okay, more?
At the end.
At the end. It's at the very end.
Thank you.
Oh, keep going. Keep going. Keep going. Again, 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 again. We're almost there. Reference 3. Okay. 2010.
And that's the
Is that okay? Anybody have a comment on that? You can go back to where we were. Everybody saw. 2010, and it's coming from the United States.
No, this is 2. The Inca that I told you was 2.
number
it's
2, there is a different one. Incidenza de
Inca.
colon
Yeah.
number Brazil, Rio de Janeiro,
I don't know what's the
2016.
phrase. I'm just gonna read it here.
We're going to go back and forth on several issues here.
Okay, let's go back to the first page.
Just one minute now. Anybody have an idea what this means here? And this? Sorry? No, it's not that. Okay, the reference is not correct for a book. I would imagine it's on page 648 that he's talking about. What's the 7 for? 7 is redundant with the 7th edition, probably. No?
Oh, chapter 7.
Okay, we'll look at that as we go along. Go ahead, go back to where we were, please. Let me ask a question to the author. Did you read those two references? You read them yourself?
Yeah.
Good. Okay, yes? Well, let's finish with this issue first, okay? If you like.
I think the reference 3 refers to this 2010 study that says that approximately 30% of the rectal cancer come
see.
from colorectal.
From
30%
yeah,
of
but it's all
colorectal.
over. It's not specific to Brazil.
Yeah, this 3 no.
Okay.
The second,
So-
the number 2 is for Brazil.
We understand what Professor Silla is saying about the introduction, and we do have something specific about rectal cancer.
Still, my opinion is that if the topic of the title and the topic of the paper is to choose to focusing on surgical treatment and outcomes and prognostic factor that influence the surgical treatment choice, I think this is a more an introduction for a textbook to speak about rectal cancer. That's my personal opinion. I think can be shrinked and just focus, okay, there are different treatment of rectal cancer. I'm not interested in how many rectal cancer are, present for the topic of the paper, but that's my personal opinion.
No, but I have a tendency to agree. I think those first 3 sentences is too much. Can we go to the next? Although there were 3 major improvements in its treatment during the last 2 decades, can I go to the next? Anybody have any comments? We have the first paragraph is very long, and then we have 4 paragraphs altogether. Remember, the goal of an introduction is what? Who can repeat what I said, yeah? Who can repeat what we heard this morning? The goal of the introduction, what does the introduction serve?
Concise.
Not the paper, but the background of the topic. But in precisely setting the situation that the goal of this paper is going to try to cheat. The goal of this paper is to analyze the results of a surgical techniques. As I understand it, is you're going to analyze different surgical techniques, and in your experience, say which technique works best as far as overall survival and recurrence. And just as a remark here, beware, this is probably a mistake that anybody could make, not even even an English-speaking person. You're combining overall survival with recurrence, but you don't want lower overall survival. You want lower recurrence, but you probably don't want lower, you want improved overall survival, right?
So I shouldn't say lower, I should say just overall survival and recurrence.
Well, I'm sure you want to identify that are associated with satisfactory overall survival and lower recurrence or whatever, but you don't want lower overall survival. Okay, so the goal of an introduction is to set the scene, what is known on the topic. And that's why Professor Boni's remark is well taken, because we're only talking about rectal cancer.
So I think I would start the introduction with the last few decades have been marked advanced rectal cancer treatment. That would be the start of my introduction. From last few decades have been marked at the top. That would be my first line for the introduction. I will take away all the previous part, because that's what you're talking about. You want to show that there are different approach to rectal cancer and an improvement, TME and neoadjuvant chemoradiotherapy, and the object of the study would be to analyze which one is the best surgical approach for improving survival according to your result. So
yeah, that's a good suggestion. Anybody have any comments about that? That's not the goal of the introduction. Well, the introduction is, I think it's a general. There's a good general statement there that in the last. First of all, we'll make a comment about that there. The last few decades, the treatment of lower has been characterized by an increased use of sphincter-saving procedures. Now, this is okay, but are all the procedures you're talking about, are they sphincter-saving procedures?
Yeah.
Okay, so that's
Some
good.
of them.
That's good. It's very specific. However, what about the sentence that's after the sentence? It is now possible to make bowel anastomosis at literally any level in the pelvic region. Do you think that's necessary in the introduction? Who says it's necessary? Who says it's not? Good. In my opinion, I think it's not necessary. These changes have been facilitated also. This is not the topic. Okay? Everybody agree? All right. You did want to, I think I saw, maybe you wanted to say something before we talked about that. Oh, you're voting, okay. Okay. So we have that comment here. Now, what about the radical resection of rectal cancer with anal sphincter preservation? Careful consideration is required. This paragraph here, this sentence here. Why is it not necessary? Does everybody agree that, does anybody disagree that it's not necessary? Okay. Why is it not necessary? This is typical of what we were talking about, this whether useless words. Of course you have to be careful. Otherwise you should be collecting garbage and not be a surgeon. Okay? Doing something else. This is a typical example of useless words that everybody uses. Careful examination. Of course it's careful. I mean, why? If not, then say why it's not careful. I don't know. Okay? Everybody understand? It's useless words. Careful. And the fact that it was done. Okay. What else did you want to say? Do you want to add something? Please use the mic. It's right behind you.
Careful consideration of what? It's just a general term. It doesn't define. I mean,
but even if he defines what it is, we're not criticizing what it is.
Whole
it's
sentence
careful.
to be deleted. Yes.
If it's not careful, you should not be doing surgery.
Careful consideration, I think, with the surgical procedure. I think to be careful at the procedure.
Okay, but forget about the sentence. Careful. It's not doesn't belong in a surgical paper. Okay. If you're not doing it carefully, then you should not be doing it.
Agreed.
Okay? What about the next sentence? The possibility of sphincter saving resection of rectal cancer is determined based on appropriate distal resection margin clearance. Same thing. It's a textbook comment. Doesn't belong in an original paper.
Yeah, maybe for the purpose of the paper that is focusing on a different surgical approach, maybe the author can also make a sentence where they say, well, different possible surgical approach have been proposed.
According to,
but
okay.
And
I would
so
accept
the
that.
objective for the study is to give us an information, say, what kind of surgical technique are you going to use it for your patient according to the result that we're going to propose. So we need to have a sentence that tells the author, the reader, okay, well, we are focusing on the prognostic factor that influence the choice of the surgical treatment, because that is the purpose. So there are different surgical treatment, and the paper is trying to answer which one is the best according to the patient. So tailoring the surgery for the patient. So we need to put a sentence, I think, for the different. But this one, I agree, that should be taken out because this is something that.
Okay. Anybody else have a comment there? Okay. Yeah, please.
First of all,
Wait a minute.
Please. Please go
He's
ahead.
first, and then but go to the mic, please.
I was just wondering, should there be some ambiguity regarding we don't know exactly what's the best, so that's why it's relevant to publish their experience?
I'm sorry, I didn't hear it.
I was wondering, should there be ambiguity about what we don't exactly know what is the best procedure?
Are you talking in general, or are you talking?
No, in this paper.
Well, that's what the object is. He's trying to determine the best treatment according to his experience. But that is no. Of course, we don't know yet, because this is what he's going to. This is what his objective is.
My comment is that it's not that there are 5 different ways of treating a rectal cancer. So is he really comparing 2, 3 or 4 different surgical techniques?
I don't know
It
yet.
doesn't.
We
So
don't know yet.
Then that will have, if it is going to be a comparison between 2 different surgical techniques, okay, then that will have to be, that will have to come in the introduction, isn't it?
Okay,
And
but
the next sentence also is ambiguous, that the objective of this study was to analyze the results of surgical techniques in the treatment. Results as to what? Analyze the surgical techniques in terms of its complications, in terms of its mobility, in terms of its hospital stay, in terms of its recurrence rates, in terms of margins, in terms
Okay.
of survival outcomes. It's quite ambiguous, actually.
I think we're going to find all that information later on, because I've read it a little bit before, so I think we're going to find that. We'll talk about that in a few minutes. Anybody else have a comment on how we can shorten the introduction? No, 1 paragraph would be exaggeration, but it's not too long, but there's a lot of useless information there. I think they could get everything done with 2 paragraphs here. 1 or 3 paragraphs. 1 being the current situation, however you state it, with or without an incidence. Sorry. Second, some statement like saying there are several ways to treat distal rectal cancer, and perhaps even indicate, according to the level, the exact level or whatever prognostic factor that exists already in the literature. Don't forget that his title is about prognostic factors. I haven't seen anything about prognostic factors in the introduction. Don't forget, the introduction is what you should know about the topic and what you want to show. He's talking about prognostic factors, so we have to have a notion of what are the prognostic factors already in the literature. Who does what with what cancer? And then say, our goal is to study the prognostic factors in our population. Anybody have any comments on that? Further comments on that?
Yeah, I think you should put something on the prognostic factor, but I think one of the innovative element of your study is to correlate patient factors and the surgical technique, which is, I think, quite, I mean, I'm not aware about many studies that actually were done focusing on this. So I think that should be a part of your introduction, because it's a strength of your study.
Exactly.
Otherwise, people will read and say, okay, well, they're telling me the result of a 10-year experience, and I don't know that, what you're doing is actually that this paper may help me out. Okay, I have a patient, he's got this prognostic factor, I do it for an APR, and I don't do it for a sphincter saving procedure because the results were convincing. So I think prognostic factor somehow should be introduced into the introduction, just to keep the reader.
Okay, Patricia, you want to say something?
So I completely agree. What you want to do is you introduce the problem. The problem is that the outcomes following resection of rectal cancer is dependent on several prognostic factors, right? So you need to introduce that in a short paragraph, maybe 2 or 3 sentences. We know it's dependent on surgical technique, right? And then features about the tumor. So tumor stage should go in there, and the use of neoadjuvant treatment, maybe. You don't have to include it, but you need to lay the land of outcomes of rectal cancer. Surgery is usually dependent or is related to, we know that it's related to patient factors, tumor factors, and surgical technique. So based on that fact, you proceed with your study, which is to really understand the impact of those various variables in your own individual institutional outcomes.
Exactly. Okay.
Yeah, maybe you can, to make it short, what you can do is you can make a sentence like, several prognostic factors being recognized for rectal cancer, and there is a references for that. There will be somebody who studied it, and different surgical approach has been proposed for low rectal cancer, and there's definitely a reference for that. and then you can go. The objective of the study is to
Absolutely.
combine the two things together, and in our experience.
Okay, we got it. Okay, great. Fantastic. Okay, so we're down to about 2.5, maybe 2.5 paragraphs. Okay, about half. So your question is how long it should be. There's no steadfast rule. I did see in one publication, I don't remember where, that an introduction should not be more than 10% of the entire length of a paper, but that's just empirical. I don't know of any journal that has any steadfast rule on how long an introduction should be, but it certainly should not be more than 1 page, that's for sure. We're almost there, I don't know, but it's not the same format, but anyhow. Okay, let's go, let's read the methods, or at least what we have on the screen. Can we go on to the next page? Okay, let's stop. Okay, can we just stop after patients with peritoneal carcinomatosis or advanced distal metastasis were excluded? What are your comments on that beginning of the material methods?
If we can come back at the first page.
Can we go back?
Because there is
back?
something
Yeah,
that
okay.
at least visually is not good. Methods, and in this study, the result. So it's already something that for me is not good. You know, you put the word result, you know,
Exactly.
immediately after methods.
Exactly. What is your objective? Your objective is to analyze the results of surgical techniques in the treatment. We have the same word here, but it's not the results, it's to identify prognostic factors, right? So, yeah, okay, so it is the outcome rather perhaps than results. Outcome is a better word?
Maybe yes.
Wait a minute, just 1 minute. Outcome, would everybody agree that outcome would be a better word than results?
I will basically put like data collected in a retrospective prospective collected database were analyzed, and that's it. I will not or from the colon and rectal surgery service of the hospital, blah, blah, blah. That's fine, but I will start the data from a retrospectively or a prospective collected database that were analyzed retrospectively. I will start with this sentence without the result, because the result or even outcomes, I think, would be...
Well, isn't it the same thing? That's what I'm trying to say. That's what I'm trying to get at. It's repeating. Results are data, right? So we want to combine that in a sentence so we don't have to repeat in one sentence results and the other sentence the data. The data is what we're looking at.
So we say data from a prospective collected database were analyzed retrospectively. I will start with this sentence.
In patients with distal rectal cancer at the whatever service in Sao Paulo, Brazil. Okay, during the period of 2002-2012. Everybody okay with that? Understand the...
Whether all the consecutive patients were analyzed or only selected patients were analyzed hasn't been mentioned.
I'm sorry?
Whether all the consecutive patients were analyzed. Sorry? All the patients
too close to the mic or something, I can't understand.
Whether all the consecutive patients were analyzed.
Yeah, consecutive patients, yeah.
If there was a consecutive analysis.
Where is the word consecutive?
No, there's no consecutive. He's asking, I'm answering without putting in the text. I didn't put. Yeah, we have to put it.
Very important. Thank you.
Thank you.
Even though I didn't understand it. Thank you. Very important. Remember, we talked about that. That's one of the basic biases in any study. Because it's even if it's true, the fact that he did not say it leads to the question, well, were all the patients included and how did he select which patients were in? Okay, very good remark, very good answer. Yes?
I have one comment. Yeah. There is nothing related to the analysis of surgical technique in this. It is all related to the following factors which were studied. In that, there is only one indirect measure of surgical technique, which is the number of lymph nodes recovered.
I imagine he's going to talk about that later. We haven't read it yet, I hope, at least. But we haven't finished the chapter on methods. So maybe it's going to come later. But that's a good remark because this is the actual, the bread and butter of the study. And we looked at the prognostic factors, but we have to look at the techniques as well. There should be the paragraph that follows.
It's not there.
As what I understand, it's not there. It's not the case. There's something else in there. We'll get to that in a few minutes. But good remark, yes. Somebody over here?
My question is the curative surgical treatment. This is the inclusion criteria of patient had the treatment for a curative intent, or when you look at the data retrospectively, you just took the patient who had a cure at the end.
Had a cure?
I mean, if you said the results of the curative surgical treatment, do you mean the patient treated with
intention
the
to treat,
intention to
cure patient. The patient didn't have metastasis, didn't have any other tumors that were that would prohibited from cure. The staging, the pre-op staging and post radiotherapy staging showed that the patient had no metastasis, no carcinomatosis, anything.
So why you put presence of distant metastasis?
What?
Because you say the following factor was studied and you included presence of distant metastasis. So that means that should be taken.
That's a little bit contradictory.
Oh yeah, that's right. I should take it out.
Well, no, it's very important. You see what happens when you analyze a paper? Distant metastasis were excluded, but it's a prognostic factor in this population. This is something that has to be cleared up. Okay, let me suggest that we're moving forward there. Let me suggest that we go to the next page and continue, because what we're missing here is the remark about the surgical technique. Let's see if we go. We have a paragraph starting with the antibiotics.
Patricia?
Let's stop at neoadjuvant therapy. Anybody have any comments?
So you're a little bit out of order. You're talking about the surgical procedure before staging. Typically, when you think about how you work up your rectal cancer patients, right? Staging, neoadjuvant, surgery. You're kind of like not particularly in a good order.
Absolute.
You're
what
right.
we talked about this morning. You have to respect
You're
the
right, but
logical and a chronological order of items. And he's going from the prognostic factors that we found on the other page, inclusion criteria, more or less, to exclusion criteria or non-inclusion criteria, which he says actually non-inclusion. That's good. Let me congratulate you instead of saying exclusion. They're not included. Very good. But you're going from one thing to the other, as Professor Silla has just mentioned. Once you start talking about inclusion criteria, do your non-inclusion criteria right away. And then start talking about something else, like, for instance, the technique. But what's surprising also is that this is the intravenous, the antibiotic prophylaxis and thromboembolic prophylaxis comes before the surgical technique. Where's the surgical techniques? Where are they? Are they later?
Yeah.
Can we go another page and see where they are?
I think that in the method there are too many things, because some of the stuff that, if you go back to the previous page, why should I know something about, the purpose of your study is still, finding the factor that influence the surgical treatment. The surgical treatment relation
And
relationship
influencing the outcomes.
with the outcomes. Yes, the prognostic factor according and the surgical treatment. So why should I know anything about how you stage the patient? I think is out of the purpose of the paper. I think if you are going, you said beginning that you are going to analyze those factors and relate this to the 5-year survival. Why should I know anything about your intravenous antibiotic prophylaxis or thromboembolic prophylaxis? Because that will not, according to what you say before, will not be analyzed as a prognostic factor. And also, exclusion criteria, okay, I agree, that should stay there. And you will have to also, for the neoadjuvant treatment, are you gonna compare also the neoadjuvant treatment with the surgical technique that you've been using? That's what you're gonna do?
No.
So if you're not gonna relate the neoadjuvant treatment for the surgical technique, I would say neoadjuvant treatment will be done for stage 3 patient, but will not go into the details of the neoadjuvant treatment, because I think that there's no point.
Because some patients did not do the neoadjuvant treatment, and then
they did not.
We analyzed comparison of patients that did neoadjuvant, and then the patient that didn't do.
Okay, I agree that you have to do the neoadjuvant treatment, but I really don't need the details of your neoadjuvant treatments. The regime that they went through. I don't think that will make significantly.
You think that
unless you did different neoadjuvant therapy.
No, it was
it was always the same. Those people that had neoadjuvant therapy had that and nothing else.
Yeah.
And can we go back to the one page? Where did you say that you studied that?
Sorry?
Where did you say that you studied patients that had neoadjuvant and patients that did not?
No, I didn't say it before.
Okay. So if this is something you've studied, you have to stay at the same time that you looked at the lymph nodes, the T stage, in the presence of this and that metastasis, even if you want to keep that in. Everything has to be grouped. We're talking about inclusion criteria. This is part of the inclusion criteria, or at least a part of the methodology. This is one of the prognostic factors that he's looking at, okay? We don't have to have it on one page and then find it on 3 pages later.
So my view is that in the methods, you should only describe your methods according to the result. Because if you put something in the methods and then you don't find a correlation in the result, then the reader will say, well, what happened to this? And why the prophylactic antithrombotic therapy may give you an influence, that it may have done an influence of your result, but you should then analyze in the result. And apparently you're not going to do it. And I agree.
Yeah. Who knows what distal rectal cancer is? Yeah? Would you give us an answer? What's distal rectal cancer?
Yeah, maybe a short definition of the group of distal rectal cancer should be.
It's a certain distance from the.
What's a certain distance?
I don't know the distance off the top of my head. I'm in college, sorry. I'm an undergraduate student.
No, that's okay. It's okay, but this is what we're talking about, okay? We don't want the word certain. Yeah. We want to have a number. We want to see it, 3 kilometers or whatever, okay? You have to define what you mean by distal rectal cancer someplace. Remember we talked about that? Definitions are very important. I'm sure that if we asked the question to everybody in this audience, we'd probably have, we have about 30 people, probably have about 15 different answers, at least. So you have to define your population. Okay, any other comments? Go back one page further. I'm sorry. Go forward. I'm sorry. So we agree that we're looking at all the prognostic factors that are going to be eventually investigated here should be in the same paragraph. Antibiotic prophylaxis and thromboprophylaxis, one sentence to say that they were done would be enough. Even if you excluded them, I would agree with Professor Boni that that's not essential. That the patients were staged and restaged. Why staged and restaged? What's that mean? Why did you restage? You weren't happy with the first stage?
No, after neoadjuvant therapy, I think. Yeah. I guess that you.
Okay, well then, if that is the case, then you'd have to say it, be more specific, more precise. Okay, and probably if that were the case, not to disagree with Professor Boni, but perhaps the paragraph saying patients were staged and restaged after neoadjuvant therapy for those patients that had it would be enough. It would get rid of those both two paragraphs in one sentence. Okay? Anybody agree or disagree with that? No? You're shaking your head no. You're shaking your head yes. All right.
I would put, and just to give I would put the references for I would say standard neoadjuvant treatment was given according to the stage of the patient.
That would even be,
and
that
I would
be
put
more preferable.
Or standard neoadjuvant, and I would put the references for the standard because that's.
I agree 100%. Okay, go next page. Okay, any comments on the surgical technique? Surgical treatment, let's say.
In the final paragraph, all surgical procedures were performed by our institution of surgeon with previous training in colorectal cancer surgery for the principle. I will stop there because the following sentence is a little bit a redundancy for the first sentence of the surgical treatment, because you already said you perform a TME with high ligation of the inferior mesenteric vessels, which is following the principle of radical oncological resection with dissection of mesocolon and total mesorectal excision. Total excision of the mesorectal associated with resection of contiguous organs. This is a repetition of what you said the first paragraph. I think that can be probably.
I agree 100%. Everybody agree? Anybody disagree?
Take it all out, all the rest of the paragraph.
No, probably decision to perform a sphincter preservation is based on the sphincter involvement during restaging. I think that can be kept. Or probably put under at the end of the first paragraph.
Okay, just a little bit of semantics. Ligation of the inferior mesenteric vessels in its roots, high inferior mesenteric vessel ligation would be much better as an expression, yeah?
I just want, do you take into consideration the patient's function?
The function? No. No, it's not taking into consideration.
Okay.
Not now. Not for this word.
Decision, okay. By surgeon, so there were many surgeons doing the surgery, but there were one surgeon evaluating, doing in the methods, the page before, there was only one surgeon doing all the evaluation.
It's not just one surgeon teaching the practice for the residents for practice. It's a group of surgeons that teaches. Is not just one. It's like five or six surgeons.
Where's that information?
No.
Other than in your head?
No, nowhere.
It's got to be in the paper. Okay, I'm going to go through. I'm going to read something out loud because I think it's exemplary of some of the comments we made this morning. However, the surgical technique consisted of, okay, surgical options included. So we have two options. Then we have however. Why however? However, a resection margin of 1 or 2 centimeters was difficult to achieve when rectal cancer was located close to the anal-rectal junction. What is that? Is that part of your technique? Don't say anything. Is that part of his technique? What is that?
Like a discussion.
Not even the result. It's a comment. It's doesn't belong in methods. It's a comment. This is everybody should think about it, but it's not part of his method. Don't forget, methods and results are methods and results. Nothing else. No comments. No discussion. No sentiment. Whatever. Okay.
So
if it were, as Professor Talamini just said, if it were result, then it should be in results, but it's certainly not in methods. In such cases, the specimen was resected to the farthest possible location from the lower margin of the tumor. What is this? Is this a method? Yes, more or less. Okay. So in other words, in such cases, referring to a margin, no, when cancer was located close to the anal-rectal junction, that's all you need to say. In cases or in patients, let me make another comment. When you talk about a human patient study, these are not cases. These are patients. Okay? Don't use the word cases. Use the word patients. Okay? So, in patients with rectal cancer located close to the anal-rectal junction, the specimen was resected at the farthest possible location. What does that mean? Farthest possible location would be what? Would be a resection. Always. No? What is the farthest possible? How far can you go?
Preserve the muscle.
But without taking the muscle, the far you can go, like the dentate line or close to the dentate line. That's
no. The expression is not. It's not said. It's not correct. It said the farthest. You need a distal margin, okay, that you can define. But the farthest would be that all the patients would be having abdominal perineal excision or resection. Okay? Everybody understand the word farthest? Farthest means as far as possible. Okay?
So I should change to...
You should remember precision, clarity, concision. What's the precision? What would be precision?
How many centimeters or how many?
Exactly. At least 2 centimeters, at least 1 centimeter, at least 1 millimeter, whatever your technique is.
After now in neoadjuvant therapy, this precision doesn't exist.
No, that's a comment. That's a comment. You define what your technique is, and because you have patients that had neoadjuvant therapy, you probably have to define what your resection margin is for patients who do and do not have neoadjuvant therapy if it's different. Yes?
What you probably want to say is that you should say, and it sounds like, if I'm interpreting well correctly, you're trying to say every effort was made to achieve a 1 to 2 centimeter distal margin, but in cases where that could not be achieved because how low the tumor was, every effort was made to achieve a negative distal margin, period.
Yeah.
Okay? When you were trying to achieve a 1 to 2 centimeter margin, but when it was too close because the tumor was so low, every effort was made to transect below the rectal tumor to achieve a negative margin.
Okay?
That's it. That's all you have to say.
That summarizes exactly what we're talking
Thank you.
about.
And then the issue I have is that other sentence. So that sentence that when you start with when a tumor, I have no idea what you're trying to say. It's complete gibberish to me. Can you take us through that sentence? Because it's very concerning. I don't know what you're trying to say, and it's troubling.
Which one?
When a tumor was neither visibly detected nor observable on pathological examination of its frozen section, so I'm assuming when you send a frozen section because you don't know where it is, TME was performed regardless of the length. I have no idea what you're trying to say.
It's completely...
This is when you restage the tumor.
No. We're talking about... You can explain it as what is like, but the sentence as it is doesn't make any sense whatsoever. I don't know. So explain what you want to say.
That when we restage and have no tumor, we do a TME anyway, and resect you do the neoadjuvant therapy, and you have no tumor after all, and then you do the TME anyway, and that's it. That's what I meant.
Okay, I understand what you're saying, but it has to be said in a different way. Sorry?
Yeah, complete.
Take
response.
the mic, please.
Complete clinical response, not pathological, because we don't have the pathology yet.
Yeah,
I think
but
it's
he's
a
mentioning
complete
that pathological exam.
Exactly. Well, that's our frozen section. So no, but there's a lot of problems here, not just one. So this means, if I understand correctly, all your patients get frozen, get a frozen section before you decide to operate on them or not.
No.
So
I think that this is what
no. Surgeons don't think; they know. So, go ahead.
No. What we meant when we wrote this was to, if we don't have the tumor before, like a clinical response, and we take it out and do a frozen section of the distal margin, and there's no tumor, so we stop there and put and make the anastomosis, or that's it. I think it's what.
That's not what you said just before. You said that irrespective of what happens after neoadjuvant therapy, you do a TME anyhow.
Yeah. So I think we should take it out. Just take it out.
All right. I have another question going back to this resection margin of 1 or 2 centimeters. Anybody have a comment on that? Is it 1? Is it 2? Is it 1.5? Well, I don't know what, but certainly not 1 or 2. Why not 1 or 3 or 4 or 5? Okay? Precision, clarity, concision. Yes?
I was just suggesting in this sentence, you just put in complete responder to neoadjuvant chemotherapy. We do TME resection anyway, rather than take it out. Be much clearer and serve the...
That would summarize it very, very succinctly, but probably very good, yeah. I'm sure that all this can be described in one, perhaps at the most 2 sentences.
If we are going to keep that sentence of complete clinical response, TME is anyway done whether there is tumor or no tumor. Where do you resect? At what level from the anorectal sling or pelvic floor do you resect? How do you determine where do I put my stapler if there's nothing seen? Well, normally that is done as per the pre-neoadjuvant chemotherapy level of the tumor if you don't find any clinical response.
Well, that's a good question as well. This has to be given in detail. So if we have a tumor that's detectable, you say you're going to either a 1 or a 2 centimeter margin, okay? And in the event that there is no tumor, the complete tumor response, you don't find any tumor, where do you resect? What's your level? What's your distal level? What's your distal level of resection?
When there's no response, or
when there's a complete response, you don't have any tumor anymore. What you said.
We do the TME and
no tumor is not detected.
We do as further as we can and do the.
What's the furthest that you can?
It depends on where the tumor was before. If it was
okay
on 5 centimeters.
You don't say that. You have to describe all. Now we're getting into a lot of details that this has to be described. You haven't described whatsoever all these details.
You're getting it rough because you're in a crowd of people who do a lot of rectal cancer. So we're gonna torture you on this. But the idea is, even if it wasn't rectal cancer, the idea is, your manuscript is gonna be reviewed by experts in the field.
Yeah.
So you're in a world of expertise now. You're not in a world of general. So you really need to be thinking about everything that somebody's gonna read. Your article is going to have, especially they do things differently than you. Now, rectal cancer is pretty protocol now, right? There's standardized protocols, including the ones defined by Haber-Gamma in your own country. So you need to make sure whomever picks up your manuscript, whether they're from your country or another country, are you holding up the standards of rectal cancer surgery? So we're nagging on distal margin because everything, and we know you're talking about the outcome being recurrence, right? Yeah. Long-term oncologic outcomes are specifically defined by whether or not you have achieved a R0 resection, a negative margin resection. So you need to be extremely precise about how exactly you're performing your operation in all these various scenarios. Tumor has no response, you can see it. Tumor has had a complete clinical response. How did you assess it? And how did you deal with it? How did you make that decision in the operating room? Based on what criteria? And how did you confirm it? And how did you salvage it in case you had a positive? So the entire range of the situations need to be described in exquisite detail.
Thank you very much.
It will take you some time, but will be very effective. This paragraph can be turned up in a flowchart of your decision-making treatment for your patient. Okay, you have a patient, tumor 1 centimeter from the anal verge. How does you treat it? Have neoadjuvant chemotherapy. Complete response, are you treated? Not complete response, are you treated? It'd be very complex, but that would make your life easier in the description because you have a set in your mind, you know how you treat this patient, okay? And so visually you can say, okay, rectal cancer. This patient have neoadjuvant chemotherapy, yes or not? Not radical resection. Radical resection, sphincters 3 centimeters from the anal verge, intersphincteric. Abdominal perineal if it's 1 centimeter from the anal verge and stuff. And so when you do the description, you say, well, the treatment is described on the flowchart number 1, and you will give a very nice visual, and you will give into details, but with a flowchart. So maybe useful. It will take you some time because it's a difficult flowchart, but it makes the difference. There is one other comment.
Let me just want to add one thing. And even if you did not publish that, that would give you an idea of how to write your chapter on technical technique. It would help you in the writing. Yes. Yeah. Continue.
The other just is a formal comment. You said resection with perforation of the sphincter or abdominal perineal resection, APR. There should be the opposite. You should leave APR out from the bracket and put APR in the bracket. The acronym was APR should be in brackets and leave out.
Yeah, that's a detail, very important detail. You should say, you should give the definition without the parentheses and put the APR in the parentheses.
Yeah, that's right.
Okay? Now, let's go back further, what I was talking about before. In particular, the double staple anastomotic instrument was safely placed on the anal canal so that the donut ring could be properly formed. Any comments on that statement?
Yeah, safely is a comment. It's
safely is a comment. As useless as the word we talked about before, carefully. What about the whole sentence? Is that important? What about the rest of it? Safely so that the donut ring could be properly formed.
That's obvious.
Useless. Okay.
The double stapling anastomotic, the stapler is not placed on the anal canal. It's placed in the lower rectum. That is 1 and 2. the donut ring could be properly formed, could be avoided because it's naturally, one has to get a good donut. So that's the purpose of a stapling. So these are the two comments.
Yeah, I think this direction. But it's you said it's useless anyway.
Yeah, you can take it out and spend more lines to describe your decision making for the patient, unless you put a flowchart.
The whole
Okay,
sentence.
something very important that's not expressed. Okay, yeah, go ahead.
Also, I think the primary objective is recurrence, and we are not looking at the post-operative complication and everything. So do we need to go into detail about how the anastomosis was done in the method section if it does not correspond with the result we are showing?
What post-operative complication you talking about?
Like anastomosis leakage or something. Like I think that's what it corresponds to. Like,
So where would you put that?
I would completely take out the how I do my anastomosis.
I'm sorry?
I wouldn't put the details on about the anastomosis at all.
Everybody agree there? Okay. All surgical procedures were performed in our institution by surgeons who had previous training in colorectal surgery. Training enough? Do you have board certification or something like that in Brazil?
Yeah.
Well, why don't you say just that?
It's not. It's
By
not
board certified. And all surgical performance were performed in our institution. Any comment? In our institution. What is he talking about? What is his population? His population is in his institution, I would suppose. So 3 words, again, that don't need to be there. Okay? Who had previous training and certification, okay? Followed by the principles of radical oncologic resection with dissection of the mesocolon and total excision of the mesorectum associated with resection. The breath taste, okay? I can't finish the sentence without breathing. Remember that this morning? Who was there? I see new faces that were not here this morning. We talked about the length of sentences. Any sentence that you can say without taking your breath is okay. If you have to take your breath in a sentence, it's too long. This is a perfect example of a sentence that failed the no breath test. Okay, let's look at the content of the sentence. Dissection of and total excision of mesorectum associated with resection of contiguous organs when adhesions or macroscopic tumor invasion occurred. Comments? Is that important? Mike, take the mic, please. We have the mic over here.
I think if he does a flow chart and go into details of the procedure, then he won't need to go back and repeat that. There will be a repetition.
Not repeat that, but I haven't seen that before.
No, but that's what we discussed before. Like they will go into detail when we preserve the sphincter, what margin we want. It's like
Can I go back a page here? Go back. One more. Following factors were studied: sex, age, tumor location, number of lymph nodes obtained in the specimen, lymph node development, T stage, and presence of distant metastasis. What's he talking about now? He's talking about T stage, yeah. Should not be all together? Or does he have to go into detail about that, you think? Did you analyze according to what the adherence, the tumor extension was?
Yeah. Yeah, we analyzed according to the T stage, not the
So
tumor
you've already said that
extension.
here.
If it's the
Is it
T4,
necessary that you go into all those details afterwards? Go back to where we were. Go back to where we were again.
You think I should take it out because if it's an organ adhesion or anything?
Any comments about whether this is necessary or not?
No.
Mike is coming.
I think it's a repetitive problem is you're describing what already had a title. So this one is en bloc resection.
Yeah.
You just described the en bloc resection. Can put instead of all this sentence.
Yeah, but when I
resection.
put the block resection as one of the factors in that first paragraph, and then forget about it. You don't have to go into, everybody knows what, or should know, what en bloc resection is in this particular instance.
Yeah, and also we say the beginning of surgical treatment, we say that rectosigmoidectomy with TME. So that is already described.
Okay. Last comment here. Yeah. The decision to perform a sphincter preservation surgery was based on evaluation of sphincter involvement during restaging. Once again, we have to know what that means. You have to define it. That means after neoadjuvant therapy. In order to obtain adequate distal and circumferential oncological margins. Any comments?
I would say that the decision to perform a sphincter preservation surgery was based on evaluation of the sphincter involvement during the preoperative workout, because if you had a sphincter involvement even before neoadjuvant therapy, you should not consider this, or you did. So you change your strategy according to the result of chemoradiotherapy or not, because if you did not, as I think you should, you should always say, if the sphincter was involved preoperatively, we should do an abdominal perineal resection. If was not involved, we can do a sphincter preservation. So that is not clear here, because, and plus you talk about restaging. What about the patient that did not have restaging because they did not have chemo? Radiotherapy.
Exactly. That's the 100% principle, remember? We have to talk about all the patients in our study. If we talk about one particular subgroup, we have to talk about all the other subgroups that we account for 100% of our population.
And you really have to clarify if you change your strategy according to the restaging, because this is not common practice. The common practice is that you have involvement on the neoadjuvant chemotherapy, you should not change your strategy. Still, you will go, because that is not the purpose of chemoradiotherapy. It's not the purpose of increased sphincter preservation. The purpose is to reduce local recurrence.
Okay, good remark. And then let me restate, what does anybody think, or does everybody think? In order to obtain adequate distal and circumferential oncological margins. What about that part of that sentence? The decision to perform a sphincter preservation surgery was based on whatever in order to obtain. What is that? It's a comment, okay? It's not part of the technique. Everybody should be doing that, right? Let's read results of a total of 928 colorectal cancer patients. Let's read from 2002 to 2012. This is results. Can we go back to methods? Stop. All right. 2002, 2012 is already here. Does it belong in methods or does it belong in results? We already put it in methods. You decide. If you want it in methods, it's okay, but you don't have to repeat it in results. If you want to put it in results, you put it in results. But you don't repeat it.
The period, right? Take it out from the methods, or
you decide. You want it in methods, you want it in results. It is a retrospective study. Probably belongs in methods. Okay?
It should belong to methods then.
Go back,
I will keep in methods.
Keep it in methods,
and then
okay?
put only the numbers on the results. Only the number of patients in the results.
That's all. You can. I would even include the number of patients in methods. This is not a prospective study. It's part of your patient. It's part of your patient population. The number of patients. But anyhow, we'll talk about that in a while. Yeah, you comment?
I just wanted to know if you have to talk about like having a ethical approval or a board at this point in the method. Just a general comment.
You could talk about what?
That your study was approved by the hospital. Is it there that you will put it? Or?
Sure.
100%. You should have some sort of an IBR, IRB, whatever approval. This is a patient. This is a human patient study, exactly. Okay, so listen. We're talking about a prospective case series, right? Prospective case series is the number of patients should be in methods, not in results. You haven't done anything in the methods to obtain, I don't know how many patients. Everybody understand that? All results have to be the result of a method. If you look for the number of patients, then they should be in results. But here we have a population. We determine how that population was obtained. We determine how it was obtained in the methods. We go back to results. Okay, so what about that first sentence?
Well, I need to read it because the first sentence you talk about rectal cancer, distal, proximal, intraperitoneal rectal cancer, extraperitoneal rectal cancer. So I think you should focus on your target, distal rectal cancer, and then we'll come back to the definition.
Exactly. Okay. Here we're looking. He's talking about. He's very proud of the fact that he's 928 patients, okay? Elliptism, triumphalism. He's showing that we have a lot of cases, okay? But in 10 years, that's 92 patients a year, 93 patients a year. Maybe he's a little less proud about that. And 30% or 42%. About 35 patients per year. Okay? Next page.
But I should put all this data, or just resume to the included patients.
Once again, you answer the question yourself. In results, we should find the result of our methods. Your methods was what? What did you say in your methods?
To analyze the distal rectal cancer patients.
This is part of your methods. Okay? So you looked at all the factors that would be possible or potential prognostic factors of whatever you're going to define. That would be your results only. Okay? Your patient population was defined to begin with.
Yeah, probably you should put, like a sentence like in the methods, 148 patients with low rectal cancer were analyzed from a prospective database collecting,
exactly.
Collecting a certain number of colorectal cancer in 10 years' time. And
Leaving
then here you start from the prognostic factor that you want to analyze.
Exactly. Okay? Get rid of your patient population and methods, and don't talk about it anymore. Your topic here is prognostic factors. That should be your results. Okay? And the sentence here, leaving for present study 148 patients even if you put that into the methods, that's your selection process. These are the 148 patients with distal rectal cancer as defined by our student here who has a precise idea of what distal rectal cancer is now.
And you don't really have to even, to me, I would personally would not even mention the entire number of patients that were collected into the database.
Absolutely, absolutely.
You don't need it. And actually, that will, because 148 patients is a good number of patients, but then if you compare with 9,000, that will look even smaller. So if you really don't want to put more attention on, because still you're analyzing 148 patients, that is fine, because you're looking for the prognostic factor.
That's exactly what I was getting to with my comment before. Okay? Okay, so let's read the entire paragraph until table 1.
Table 1, I think it came out for this, I don't know when we changed from my computer to this one.
Okay, doesn't matter.
We'll worry about that later.
All messed up.
Let's read the rest of the text until we come to the word table 1.
That's interesting. It's an interesting. Can I make a comment?
Sure.
Because it's stable. So yeah, here is a classic thing. You are repeating what is in the text in the table.
Exactly.
I would just put, demographic characteristic of the patient and the pathological, I can't read very well, but are described in table 1. That's it. Otherwise, you are repeating things.
But I agree. But the only concern I have here is that age, whether they had neoadjuvant therapy or not, tumor staging, total number of lymph nodes, I don't know what compromised lymph nodes, yeah, okay, that means invaded, I guess. All of these are the prognostic factors that you're talking about, right?
Yeah.
So, you could probably have one table, if you had one table just for patient characteristics, I would put in a table with patient characteristics that only include the prognostic factors that you mentioned in methods, and that's it. Yeah. All this other information is not necessary. And especially, why are you stratifying the age here? Yeah. Why do we find the stratification of age, when stratified by age, those younger than 40 years?
Especially because in the methods, you didn't mention age.
You didn't mention it in the methods. Why are you doing it here in the results?
I think this age, I think it's because some patients did not do the pre-op chemoradiotherapy due to age. So
that's part of your methods. You should be in the methods. You say patients under 40 didn't have whatever. That doesn't belong in results. Okay? Once again, methods are methods, nothing else. Results are results of the methods and nothing else. Okay? Another comment here. Let me see.
As for the table, I would put the column total before the two type of
yes, that's a good remark. Total would be the first column.
If we want to put the total, because probably would be even. You can even just leave the two results for the two type of resection.
No, I would keep the total. I think it's good.
Well, if you put the total, we put total first, and then you do the two thing.
It's not obvious because it seems to be superimposed here, but okay, thank you.
Oh, better.
That's much better. I take a look at it here.
Are you talking about the pathological staging? Then you should say pathological staging, like the tumor after it's been resected, right? The final pathologic staging.
Yeah, pathological staging.
Okay. And there's a description, you know, it's either P, usually PT2.
Yeah, it's a PT.
You have to use a standard conventional way of describing it. If it's been radiated, it's YPT2. So just for the reader to understand.
Yeah.
YPT2 did neoadjuvant therapy. That's
Yes.
why, because of the distance from the anal verge to preserve the sphincter, to try to preserve the sphincter.
No, Y refers only strictly to radiation, whether they receive radiation therapy.
Why only YT2 patient received radiation therapy? That's
Yes.
why I was asking.
That's the standard conventional way of describing your pathology, your tumor stage after resection.
There were some patients that didn't do the radiotherapy and were included here.
Then just put PT2 then. If you don't want to separate them out for the reader to see, you can just, at least you say PT2, because if you say T2, it could be the preoperatively staged
I know.
patients versus the post. So
You're
just
right.
be very clear with your terminology.
Like P and Y, P or Y.
Okay, take a look at some things here. We have the tumor stage. We have in situ 2, 3, 4. Any comments? Absolutely. Is that a T1?
No, in situ is before T1, like in a
Okay, well, what happened? Why? If you have in situ and then go to 2, everybody's going to ask the question, why did he not include T1s? No T1 tumors. Strange.
Yeah. And I think you should separate the neoadjuvant chemoradiotherapy patient and the patient that did not do chemoradiotherapy.
Well, he's done that.
Yes, but in two separate tables, because otherwise would be if you start putting Y, TNM, and PTNM, that would be very confusing in one single.
Okay, that's a very good remark, but it does make an emphasis that maybe is not the objective of the study. In other words, if you did a separate table there,
the emphasis is
that
neoadjuvant.
would be the main comparison. He would be insisting on a main comparison. It's okay if he wants to do it. I'm not arguing against it, but if you do that, you give a special importance to that characteristic that might or might not be the objective of the study. I'd like to make another comment on the table, just details. You have the word gender, and then you have male and female. Male and female should be indented. Okay? You have a notable category, gender, which contains male and female, so those should be indented. Then you have age, and let's say you did a characteristic which included stratification, the same thing. Age, 40 or less, 41, 60, more than 60 should be indented. Okay? Neoadjuvant therapy, indented. No, yes. And I would put yes before no. T stage, in situ, 1, 2, 3, 4. End stage. So forth and so on. All these should be indented. Now it's coming a $60,000 question. You see p-values all over the place there. What are they for? What's the meaning of the p-values here in patient characteristics?
It's probably to demonstrate.
I'm asking you, yeah? Or anybody.
I think this was just to know if the characteristics analyzed were similar or not. Not to make any analysis of, oh, there were more male.
What you're looking for, if there was some sort of characteristic of your patient population that might have influenced
the result
before you looked at the factors. Okay.
Yeah, that's was the
That,
that was the
that,
reason.
that seems very reasonable. But what is the p-value? Remember what I told you about a p-value?
It's the rejecting the null hypothesis.
Okay, okay. So for gender, everybody agrees there should be as many women as men. That would be the null hypothesis. P-value is okay. Age, you've done a stratification. So what you're trying to prove that there is no difference. You're assuming that there is as many patients in 40 and less, and 41 to 60, and more than 60. Is that reasonable? Can you establish a null hypothesis there? Let's admit the fact that you want to stratify. Is that reasonable? No.
I think you can't.
No. So if you did do that stratification, certainly that we have to define it, and then the null hypothesis, I don't know if that exists. Anyhow, let's go. Neoadjuvant therapy.
It's a comment.
Can you?
No. Are you comparing the characteristic of the patient that had rectus hemorrhoidectomy to APR?
Yeah.
Okay.
I think it was not. I have to.
Where is that? Where is that indicated?
Yeah, I have to write it in before. I think I did. We didn't write. We didn't make it clear for the reader. I think, for sure.
Same thing. End stage, negative and positive. Can you make a null hypothesis there?
No.
Okay. And you're almost you have a p-value here that's 0.757. You have another one 0.71. You're going to take that into account someplace?
No, I think
that's a trend. It's almost statistically significant.
Yeah, but that might be because of the neoadjuvant therapy, like patients that didn't have neoadjuvant.
Did you talk about that in your discussion?
No, I didn't talk.
Okay, that would be a good idea to do it. Everybody, we're going to stop just a few minutes here because we're losing people, and I want to make sure that everybody is following and they're not here just to look at their computer or sleep. I want everybody to be here actively participating. I don't want to lose you. Is everybody following? Is everybody understanding that the critical appraisal is something that has to be done that the writer cannot do? He's intoxicated by what he's writing, completely. And you ask him a question, he has the answer. He knows what he's talking about. Okay? But he hasn't written it correctly. We're here to write a paper as much as to criticize what he should be doing in the process of how to treat rectal cancer and so forth and so on. That is something, that's one thing. But we're also here to point out that medical writing is an exercise that requires knowledge. Everybody is knowledgeable here, but it also requires putting into words exactly what you know. And this has been an exercise, I hope, has been helping you to understand how that process occurs. I would suggest that we go to another topic. Who has another paper? Would you give that in electronic form? Thank you very much. I think we have to applaud the effort of somebody getting dissected.
Thank you
now
very
the
much
paper
for
should
the
be accepted
without
for surgical
anesthesia.
endoscopy.
not even you two guys, but everyone in the audience.
Thank you.
Right. So once again, critical appraisal is a skill that one has to, that we're doing here, that has a twofold value, twofold interest. It's necessary for the writing of a paper, of course, but it's necessary also in the discussion. And what I'm going to suggest in this analysis is that we read the title or reference, whatever, once it comes up, and we go right to the discussion. Or we'll read the, I hope you have, do you have a summary?
I have the abstract, but it's not complete yet. I just put the abstract for the meeting, and it needs to be shortened.
But we'll see. Can we have that on the, once we see it on the screen, we'll take a look.
Let me check.
Yeah, I told them. I asked them.
What's the title?
Yeah. That's
Can you make that a little bit bigger? Even if you do it electronically, just for us.
Just change the font. If you can change the font size or something.
Can you change the size of the characters?
Well, they don't say here. They say that.
Thank you. Okay, let's look at the title. No, stay there. Okay. Educational impact. No capital letters for the words other than the first word. Educational impact of a new educational impact of a new educational system based on the checklist for the training of laparoscopic inguinal hernia repair, a multi-center prospective randomized controlled trial. Trial, not trail, trial.
Yes.
Comments?
I was thinking about redundancy in the title. I think we can omit educational in the first part so that it be impact of a new educational system.
That would be okay, yeah, sure.
Yeah.
Based on the checklist. The checklist.
Yeah.
What's the checklist?
Yeah. Based on.
Remember what I said about the word the in the title?
We should put A as an article.
The would be something very particular. The, or the. Put the emphasis on it. For the training. Once again, the. Get rid of those words in the title.
Yeah, I get it.
And a randomized control trial.
This is based on, this is the checklist we had already developed and published. So that's what I was talking about the specific checklist that we had already published. So that's why.
It's a specific, it's your checklist.
Yes.
Okay, well then say it's your checklist. Find a way of saying it.
Okay.
I want to make another comment here.
Yeah.
A multi-center prospective randomized controlled trial. Can a randomized trial be other than controlled?
And can be retrospective.
Huh?
Can be retrospective.
No, randomized.
No,
randomized.
Yes, but cannot be retrospective. Okay. So prospective as well is.
Yeah.
A randomized control. First of all, a randomized trial cannot be retrospective.
Yeah, so that's another case of redundancy.
So prospective, get rid of it. Yeah. And it's by definition a controlled trial.
Yes.
Everybody knows the word RCT. There's a lot of papers on this. Think about it. People have said, why do you say it's controlled? No, it's not controlled, it's clinical. It's clinical. Okay. So RCT should probably be a randomized clinical trial. There's no sense of saying that it's controlled. Randomization is a control by definition.
Okay.
So if you want to say RCT and stay in the abbreviation of RCT, it's a randomized clinical trial. So multi-center is important, randomized is important, clinical trial is important.
Okay.
Somebody else want to make a comment there? I cut you off, I think. You want to make something other comment?
No, nothing else.
Okay. Can we go to the...
Abstract.
Anybody else have any comments on the title? Okay, let's go abstract. 250 words.
It needs to be 250 words, but it's, I think, currently 390 words or something.
You think what?
It is currently 390 words, so it needs to be...
Okay, that's something you have to work on.
Yes, I'm working.
Let's read it and find out what you're talking about, so then we can go to the discussion.
Okay. Can we go down? Down again.
I hope everybody's reading as fast as Luigi.
Oh, sorry, Benny. Spend a lot of money in the fast reading courses when I was younger, so that's probably.
Can you go back to the methods? Okay, stop. Okay, we're talking about, can we go back to the title? Any comments on the title now?
There is a blinding process in the methods, if I'm not wrong.
For one?
That should
and
be.
What is the new educational system?
Okay.
We know what it is now. So why not say it in the title? New educational system. Very vague. We know what it is. Simulation, okay? So, impact of simulation.
It's not simulation. It's not simulation.
Sorry?
It's not simulation.
Based learning.
I'm sorry, then I was misunderstood.
Scroll back down, because you use the term simulation. I don't know why you even use the term simulation. You're not using simulation in the study.
So it's not.
Where is your simulation model?
It's not there.
You don't have a simulation. So
no.
The simulation part is, I don't even know where it comes from. Why are you using simulation in the, you mean practice?
It's just a dry box and surgical educational video. The reason I go into the background is, I think...
yeah, but using the term simulation, you're misleading the
Okay, my fault, yeah, sure. Okay. Simulation doesn't... What are you talking about? Yeah.
It's not simulation.
So actually what you're doing is you're
trying to establish...
You have a checklist, that's all. That's what you're trying... People had checklists or not?
Yes, it's just a systematic... the systematic way, we are trying to just go through the educational systematically without use of simulation, so that we can reach the wider, that's what I'm trying to say, wider
it's a training model, it's a training box or training module. You just have to be careful with...
It's just a surgical video and the checklist they have.
Okay, this has to be better explained in the methods,
Okay.
because even I didn't understand it.
Yes. It's an assessment tool, yes.
Okay, let's go directly to the discussion. Well, first of all, no, first thing, the end of the introduction. I'm sorry. The end of the introduction. Go back, go back. No, go down, go down, go down. Go down, down. Stop. The objective of this study was to examine the educational value of this new educational system using a multi-center prospective randomized controlled trial.
So this is the title. You're repeating the title.
That's the title, okay. But at least we know that this is your objective, is to examine the educational value. Discussion?
Go down to the discussion, please.
Okay. First sentence is what?
Most important.
Wait a minute.
Okay.
Want everybody to read it? What's that first paragraph? Use the mic, please.
I don't know if there has been anything defining that word, adequately powered.
No. What is he talking about here? What are those two sentences?
So they're saying that they've conducted an adequately powered multi-center prospective randomized controlled trial.
What is that? What is it?
I know that their way of performing this study was randomized controlled trial, but I don't know this adequately.
Not the details. What this sentence, these two sentences are what? They are methods.
They're methods, yeah.
They belong in methods. They don't belong here. This is a discussion.
It's between methods and conclusion, to be honest.
Actually, this is and demonstrated that there was.
The question asked, it was the value of this new educational system. We want to have the answer. What's the answer? What is the answer? It works, doesn't work?
Outperformed. I think it's too long.
Actually, it is
lost in the long sentence.
It is one sentence which includes, and the first part includes the method. It's a really long sentence which includes the method.
Okay.
So
what does it say? What does it say? This new educational tool has.
I think that they just want to intensify or declare again their strength of this study in the discussion, because it's kind of strong method to have a randomized controlled trial. So they want to put it as their strength of this study.
Yeah.
So sometimes we've been told that in discussion part we should talk about the strength and weaknesses of the study. So the method itself is kind of talking about the strength. I think that's the logic behind that.
Okay, let's stick to my question. This new educational tool has the potential to reduce the learning curve of novices for TAP procedure. Does this correspond to his goal?
Yeah.
Conclusion, yeah.
Pretty much.
Can we go back to the goal?
It's kind of an impact, so.
It's the first paragraph of the introduction.
The last paragraph of the introduction. Last paragraph of the introduction. Educational value. What's educational value? As compared to reducing the learning curve.
Yeah.
Is that the same thing? Absolutely not. We don't know. Use the same words to define what you want to say. If you're looking at the learning curve, then state it here. Can I see the methods? Did you find the learning curve? Go ahead. Wait a minute. Stop. Go back. So stop.
Yeah,
this is.
I think it's.
Where's the learning curve?
I think it's just like the primary outcome is just a bit below the.
Go further.
Literally.
Where's the word learning curve mentioned?
It's not the learning curve, but this total score on the third case was our primary outcome.
Can you tell him to go to the learning curve?
It's and learning curve is not there.
Because there is no learning curve. I mean,
okay.
So
you can't
we
define.
Just look the third case.
How about that? Comments?
Oh, it's not acceptable.
We're talking about medical writing here, as much as we're talking about the topic. So I'm going back to the medical writing aspect as much as the contents. Okay. All the comments that we've heard today are more about the goldfish as compared to the bowl. Okay. Certainly, the goldfish is important, but I want to insist also on the bowl.
Because if you mention the learning curve, you should define how you're going to measure the learning curve.
Absolutely.
Which is always something that you should not do it, because it's the most difficult things probably in surgeries. But so in the discussion, you will have to stuck with your...
Absolutely. And look at statistical analysis. What's the first sentence there?
The primary outcome studies between,
Very specific. You're comparing the baseline, which I understood was the case that he did before.
Yes, randomized.
The checklist was introduced, and performance on the third case. Why on the third case? You have a reason?
Because we believe it would have an early impact, but the second case would be too early. So the third case, what is the reason?
You only did it on before the checklist and on the third case? That's it?
Yes, we compared to those ones.
That's your learning curve? 3 cases?
We are comparing the control and that control group and the intervention. So we wanted to look at the impact on the third case. Yes, the early impact. Not like 10, 15 cases. Okay.
Interesting.
So do we
Anybody
have a
an
general...
idea what the learning curve is for whatever criteria you want to look at in hernia repair?
Do we have any consensus on definition of learning curve?
Probably not. But you should, if he wants to look at a learning curve.
Okay.
I don't know what your definition is. Learn how to do what? Have no recurrence?
I think anybody should
not kill anybody? Do it without any anesthesia? I don't know. But certainly on the third case is a very short learning curve. I don't know how you're going to compare anything with learning curve you do. Everybody has evaluated before at baseline and on the third case. What are you looking for?
The impact on the educational system.
What's your end point?
The checklist score. We are assessing the technique. It's like, are they performing better score based on the checklist score? The assessment.
So get rid of the learning curve. It has nothing to do with the learning curve.
Yeah, nothing to do with the learning curve. So we are just looking at one point at the early stage.
Okay.
I think
And what is your delta here?
Excuse me.
You did a power calculation to demonstrate significant difference between the two groups with an alpha of 0.05 and a beta of 0.20.
Yes.
By the way, that's a power of what?
0.8.
A power of what? What's the power here?
The beta error is 0.2, so the power will be 80%.
80%, okay? The analysis indicated a need for a minimum of 5 participants in each group to prove what?
That the educational system would improve there.
So you wanted to go from what, I don't know what, to 20, is that it?
Yeah, it had 17.4, so from 18 to 20.
18 to 20?
Yes.
No, 18 was your third
case. Yes, the originally, so it went for the third case, from what we had collected, we got 18.
Oh, so you want, okay, your previous study, the score after 3 taps was 18, and now you wanted to improve it
we
to
believe
20.
that we could improve to 20 based on what they, which scores, which places they missed. We should, like with this educational tool, we can improve on those areas. So that was our hypothesis.
Okay, everybody satisfied with the power calculation there? 5 patients in each group, is not very much. Okay.
May I ask a question?
Yeah.
So I don't get that third tap case was 18.0. Because the first number has quite a confidence interval, but
not a confidence, it's a standard deviation.
Yeah, it's a standard deviation, so the other number doesn't have it, or?
Exactly. Why give a standard deviation for one and not for the other?
Standard deviation was 0 for that one.
Sorry?
The standard deviation for that third case was 0, so we got only...
Standard deviation was 0?
Yes, we only got the cases we had, all the scores were 18.
How much is your sample size?
Like for the power analysis, for the first cases, I think we had 5 or 6. For the
5 or 6 and you have a standard deviation of 0? Impossible.
No, for the first case and for the third case, they are not the same persons. So we had, for the validation of the checklist, we had a lot of sample, but we had 5 or 6 cases that were of the first case, and 3 cases with the third cases.
So you have 6 patients, 6 participants, which scores for all of them came up as 18
and
net.
3 came out. 3 of them were for the third cases, and 5 of them for the first cases. So that was the
standard deviation of 0 means that everybody had 18.
Yes, 3, because we just had 3.
Even if that were true, let's say it's true.
Okay. Yeah.
You should say plus or minus 0. You have to give it.
Okay.
I've never seen it before, but you can do it.
Yeah.
If that's what you want to say, you have to be consistent.
There were only 3 participants on the third tap.
Yes, that was
3 participants that scored the same. It might even happen. I mean, if we're 20, it would be impossible. But 3,
yes.
It may be.
Actually, this is basically flawed because of the number and the sample size. I think you shouldn't have central measures for this number. It's just a case series or something. You just report your results, because I don't know how even you were able to calculate the beta or the power of this study. I'm just wondering.
I'm wondering as well.
Yeah.
Do you have an explanation?
Because for the power of 80% or more, you should have at least in case control studies, you need to have at least 15 patients or participants in each group.
Well, it's not only because of the power, but
and the effect size.
You're going from 18. He wants to go from 18 to 20. That's a very small increment.
Effect size.
Very small increment. I would just take a guess, a wild guess. It would be probably about 100 patients in each group. Not far.
Right.
I don't understand the power calculation.
Yeah.
Okay,
That's a very small increment going from 18 to 20.
Because
the smaller the increment, the smaller the data, the more patients you need.
Simply put, it's just not a statistical study or results.
Okay.
It's just a
he has to
report.
settle that with his statistician. Something else, the student t-test.
Yes.
We didn't talk about that in detail. Student t-test, it was used to compare data between two groups.
Yes.
Anybody have an idea what a student t-test is?
It's not parametrical test.
First of all, it's written with a small t, but that's...
Okay.
What is it? It compares what?
Student T, it's a paired test. It's like a test to compare two like means or two characteristics.
Very good, right? And is there any restrictions to a student t-test? Yeah, like what? How many? 20, exactly.
Okay.
You cannot use a student t-test if you have less than 20 in each group. It's the same thing that we talked about before. It's not less than 20, it's not normally distributed. It can't be normally distributed.
It should be a non-parametric.
And it has to be a non-parametric trace. If you didn't have less than 20, you have to use a non-parametric test. You cannot use the student t-test is a parametric test.
Yes.
Okay, good. Right.
Yeah.
Good comments here. Very good. Go back to the discussion. Back to, further.
No, it's done.
Okay. That's a new educational system has the potential to reduce the learning curve.
I think that was not the important part.
What would you say? What would you say?
I think it got lost in the long paragraph. I just said it's outperformed, like the one who underwent training using this system outperformed their counterpart. I think that would be the most important sentence. Like those underwent the training using new educational system outperformed their counterpart. I think that is what answers the goal, and this should have been the most important sentence, but I think it got lost in the long paragraph. And
can we go to results to see what the results were? No, go back. Okay, stop. Primary outcome. Go, yeah, primary outcome.
It's below.
Show the paragraph primary outcome. Thank you. CG and IG, I'm sorry, we didn't see the definition. What's CG and IG?
Control group and intervention group.
All right. Central group?
Control group.
Control group. The control groups are those without the checklist. Is that it?
Yes.
So, in their first case, before I don't understand. Oh yeah, the group that's going to get. So there was a difference to start out with. Is there a p-value difference there? No, they were not statistically significant. Okay. By the third group, the score of the participants in the IG group improved significantly, while the change in the score of the participants, was not. Comments of what I said this morning. Comments on the order.
Yeah.
He's talking about CG and IG.
And
then he talks about IG and CG. Okay? Same chronological order. Always use the same chronological order. So we have an improvement by the third TAP case. Improved statistically significantly to 21. While the change in the score was not statistically significant, what was the change? Why do you give the change here and not here? Why do you give the change here
because
and not here?
because I have it in the table, so I'll just.
Okay, but if you, no, I'm just talking about the style.
Okay, yeah.
If you give the change for one, you have to give the change for the other.
Okay.
Okay?
Yeah, and it's not totally clear if the improvement is within the group. It's not between the groups, isn't it? Am I right?
Exactly.
Because
So
that is confusing, because usually when you compare the two groups, you make a comparison IG versus CG. Instead, here the improvement is within the IG group, isn't it? So that's
there's a confusion there. It's ambiguous. What we're looking at is the improvement because of the checklist in that group that did have the checklist. Okay?
So
very important remark. The difference between scores between IG and CG. So we're going IG, CG, and the third case was also significant. So not only was there an improvement with the checklist, but also there was a difference at the third case.
The score of the third case, yes.
Okay. What about that p-value? What's the null hypothesis?
Null hypothesis. There hasn't been any difference between.
There will be no difference between IG and CG at the third case. Is that what your null hypothesis is?
Yes.
Can you explain how you?
If there is no difference, because both the group are being trained, and if the null hypothesis is true, then they should have the similar score at the first case. They should have the similar score at the third case. So I think I'm working in the third case also there should have been no difference, and also there should have been the improvement should be similar from first case to third case.
Everybody understand that? The null hypothesis is that there would not be any difference. He rejects that because he has a p-value of less than 0.5. The alternative is that there is a difference and it's due to the score. Okay, I want you to understand what a p-value means. I'm explaining it in detail. I want you to understand that. And what is it? What is it? P, V? What does the P stand for?
Probability.
I want to hear it.
It's a rejection of null hypothesis.
What?
P.
The P is the false positive rate?
False positive rate.
Right? And what are you saying?
False positive rate is less than 4%.
All right, exactly. And what does that mean?
It's
you're not going to explain it in the paper, but I want you to understand it.
That is.
In other words, yes?
It is.
It's not due to.
There's only 4% chance that this finding is false.
No, but you're almost there.
Or the probability
chance.
The probability of that this finding is false is just 4%.
That's better. Okay, I prefer that. Okay, everybody understand what that means? And it's a statistically significant difference. It's not an inherent difference. It's only the result of a statistical test, right? It's not a difference like black and white between the two methods that we're talking about. It's the result of a statistical test, nothing more. And that is why you have to say there was no statistically significant difference, or there was a statistically significant difference found. Am I making myself clear? There's not an inherent difference between the two techniques. Okay? It's only a statistical test, nothing more.
I have one comment.
Yes.
I have a problem with reporting the amount of the statistical significance of improvements in each group. because our what helps the reader to understand the goal of this study is comparison between two groups. It doesn't matter if each group has improved significantly or not.
Yeah.
What matters if the difference between the difference in each group, the difference before after in each group, or the differential.
He said that. He said that those that adhered to IG, those that had that the checklist improved significantly, while the others did not.
Simply put, I'll just say that each group improved their scores, and then I'll just talk about the significance of the difference of the two groups.
Okay, you would put this phrase first, and then talk about that. Is that it?
He has talked about the significance of each group amount of improvement.
Okay.
It doesn't add anything to the result.
Yeah, I agree, but it's something that you might want to mention anyhow. I agree that your main point is the improvement because of the checklist. We agree.
I mean, no one care about if the improvement in each group is significant or not, because this is not the goal of this study.
I think
you can't say no one cares about it. It's not the principal goal about it. That's I would agree, but don't say that no one cares about it. I'm sure somebody cares about it, and I'm sure he does, but that's not the goal of the study. We agree.
Because even if it is not significant improvement in each group, the final the comparison should come up significant. See what I'm saying?
Yeah, I understand, but I think because both groups are one is going through the conventional educational and one is using our new system. So if you just keep on doing surgery, you keep on improving. So I just wanted to I think that was the reason I put the difference between first and third before comparing the third was because I just wanted to show that the rate in which because we are just looking at one snapshot of the whole learning curve, we are not looking at the whole thing. We just wanted to show that the rate in which these in the one who used our newest system improved was much more better than the one that was used by the control group, because they just increased from 15.4 to 16.4, while the intervention group improved from 12.4 to 21.3. I think that's why I felt that result was more important, and that was our initial hypothesis. We did find that the difference also was difference in the third the score in the third case. There was also a significant improvement if you just compare the third cases, but I think that was the sort of secondary data.
And there's another huge problem I have is that the conventional.
Are you satisfied with his answer?
Yeah.
Are you satisfied with his answer?
Actually, I'm trying to ask in another way.
Okay.
Any education or training should improve the skill of the participants. Okay.
Yes.
It's obvious, right?
Yes.
So why do you say it's obvious?
No. I mean, the conventional way, in common sense, is the way they're getting trained and they improve their skills.
So why do you do the study?
So they want to see if this new method.
If this is common knowledge, what you're saying, why do you do a study?
So we are trying new method in order to see if it's more effective.
Yes.
But here we see that the conventional one was not statistically significant.
It increased to the third. Maybe if we see 10 because for the recent literature, it says you need to 60 cases. So
I can help you with that.
Let him finish. He has a good point there.
Yeah.
I can help you with that because you didn't have enough sample size even your conventional method came out insignificant. That's why everybody improved, but because you didn't have enough sample size.
Yes, if we look at like maybe 10 cases, then probably that was our hypothesis. Like why third case?
You're challenging your conventional training very deeply by saying this, I think.
But yeah, because like the full marks of this checklist is 24. So I think like if you continue with like, if I continue for the 10 cases or 20 cases, they will both achieve the full marks. There will be no difference. But what we wanted to say is that for the initial phase.
Stop.
Yeah.
Once again, we're talking about different things.
Yes.
Okay? He's talking about comparing your system to whatever the traditional thing is, which is nothing.
Yes.
As compared to a standard.
Okay.
And you're trying to explain something that doesn't have anything. Answer his question.
Because that is standard in the, like, I'm comparing with the standard system we have in our place. Or like that is that is the standard training method that is outside North America. In most of the places, that is what we have.
Okay, let's go to the introduction. Can we go to the introduction? This should be an introduction.
Yes.
What you've just said. Okay, introduction for the best field of education for laparoscopic. Despite the measures, field of still infants in most parts of the world. Scroll down. Okay, so his remark is very good.
Yes.
He's talking about a new educational system where, as compared to no educational system.
Or the
so why do you call it new? Why do you call it new?
Because it's
new for the topic.
Because
it's almost a study with the placebo. It's like a placebo.
No, it's with the conventional.
So actually, you're training. You're not comparing a new educational system. You're comparing a educational system with nothing.
With conventional method.
Conventional what?
Conventional educational system. Halstead model. Yeah.
What is the conventional education system?
Halstead model, like you learn by seeing your experts.
Where is that? Where did you state that?
Okay.
Where is it written?
The idea is good.
Once again, stop. I don't want the fish. Yes. I want you to look at the bowl.
Yes.
He knows perfectly what he's talking about, okay? But he hasn't expressed it. Okay? The lesson learned here today is you know what you're talking about. You have all that knowledge. Medical writing means it's the skill of transferring what you know into words. Mm-hmm. He has not done it. Or whoever wrote the paper has not done it correctly. Okay, I want to make that point more than the fact that they were comparing something. The fish is okay. We're not going to talk about the fish. I want to talk about the bowl. Okay? Everybody understand my point?
Sure.
Okay. Can we go back to the discussion and we'll have a few minutes on this and then we'll call it quits for today. Okay, just tell us what did you discuss here?
I just was discussing.
I'm looking here. The first sentence I see in this second paragraph. These assessments and formative feedback. Assessments and formative feedback.
That was what we did with the checklist, with the intervention group. We assessed their video, we gave them feedback.
Can I go back to methods?
Yes.
Yeah. I don't think it was there.
So it's the training of the intervention group. It's
Where
down.
is it?
It's go down. Training of the intervention group down.
Okay, stop. Participants and instructors were notified which group they had been assigned after the pretest. Wasn't blinded then. Participants could not be. The instructors, who did the evaluation? The instructors?
Yes. No, the blinded video raters.
Somebody else?
Yes.
All right.
So
the participants and instructors were provided with the teacher and educational tool and the checklist. They were briefed on how to use the, Participants were provided with assessment of the first procedure. And were asked to review the educational, They were asked to practice in the dry box. Researchers tested the predator allowed to perform the first set. They already passed the pretest and were allowed to see 3 minutes. By giving feedback to the trainees, is this what you're talking about, the feedback here?
Yes. So that's our, our results showed that these group improved significantly. So in the discussion, we are sort of discussing, discussing our hypothesis on why do we think they improved so much.
Okay, I don't understand either. You're testing how they do the knots, or how? What's your endpoint?
It was
the rating. The rating is based on what?
The actual TAP surgery they performed.
The
laparoscopic inguinal hernia surgery they performed.
Like what? What's the rating based on?
It's based on the assessment score. So it's like if they did all the procedure correctly or not.
Very.
No, it's we had validated assessment using validated assessment tool.
What did you evaluate?
The surgical procedure itself.
How?
Using the video and a validated assessment tool, the checklist.
Did you define that? Where's that defined?
It's if you go down the blinded. If just go down a bit. The blinded video rater rated the video.
Yeah, but I mean, what kind of was it? A visual analog scale? Was it?
The TAP checklist was.
There was a checklist.
The checklist. In other words, you did it. You did not.
We have already introduced the checklist. It was. We have already published it, and so that's what I just put it in the reference.
All right.
So that's what you used. So we have given detail about checklist in this paper. We just put it in the
usually is the task was performed yes, no,
sort of yes,
partially or something like that.
Yes.
Okay. Okay, go back to the discussion. Now that we understand what the feedback was about. Stop. Okay. I made a comment here. Anybody have what I said about the verbs? Hashimoto and Al demonstrated that the quality of performance of the novices was higher in simulation training. That means what? If you say that?
It's a randomized control trial.
Did he do a randomized control trial? Is reference 11 a randomized control trial?
13 was 11 was a randomized control trial.
Good.
All right. Good.
Exact. Okay, you can say it. No, that's good. If it were not a randomized control trial, what should you say? How should you phrase that sentence?
Instead of demonstrated.
Let's.
Sorry?
Suggested.
Found.
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 Yeah. Okay, good. Even though you're only one there, you retained the lesson. That's good. Okay. Other studies. Interesting.
Yeah.
Other studies. Where is it? Why isn't it the same here? Okay. Other studies have also similar conclusion.
Okay.
Okay, let not discuss whether the other studies. What's other studies?
You need to put.
Whose study? Who did the study?
There is no reference on that.
No reference.
Yeah.
If you talk about a study, you have to have a reference.
Okay.
Everybody understand?
And have to be randomized control study because you refer to the also
Ideally,
similar
of course.
conversation, so that otherwise.
And something else, which you see all the time. He says other studies. That means at least two references, not one, at least two. Despite the, yeah?
I was referring to I think it was recently quite a few studies, and then I picked up one main study that was RCT and just continued it. Yes, I think all the others are not.
So the other studies are not the same.
It was I meant the same thing, but yes, I didn't.
You meant the same studies?
Yes, to 10 to 13, but I didn't give the reference, and they are not RCT, so I cannot say.
Okay. But then, once again, he knows what he's talking about, but he hasn't written it like it's supposed to be.
Yes.
Okay, let's take another thing. Quite a few studies. What's quite a few studies? Quite a few.
Either quite or few.
Several probably would be better.
Few studies, yeah, several.
Okay, despite this education lacks a tool for that is already present in the hospital, that was made significant progress. Here, okay.
This is our result.
This is your result again.
Yes.
But you're trying to say that even though they didn't have the dry boxes, or even though they did not have another tool other than the dry box, they still, is that something that you proved in your study?
Yes. We have, they were...
All the participants in this study are under this category? In other words, all the participants in this study did not have any other tool other than a dry box?
For my study, yes.
Yeah, and all of them did have a dry box?
Yes.
Was that stated in the method?
Because for the intervention group, in order to get the TAP surgery, they had to prove that they could perform the intracorporeal knot in the dry box. So.
Good. Then you can say what you said. That's good. We did not record the amount of time they spent on the dry boxes. The participants went through an educational measure multiple times. This is methods. What's it doing here in the discussion?
Nothing.
Why are you repeating the message?
Okay.
First of all, have you put it in the methods?
Yes.
Okay, why are you repeating it here?
No, we didn't. I didn't. Yes.
Once again, if you repeat something in the discussion, you have to discuss it.
Okay.
And discussing it means what? What did we say today? What is a discussion?
The discussion is that although, because most of the educational tools that are coming right now, education system that is mostly exclamation based, and we are not. This is not exclamation based, so there is nowhere to do the technical training except the dry box that's already there and the simple intracorporeal suture and thing. So we just wanted to emphasize that despite of this, our trainees did make significant progress.
Yeah, well, okay.
So,
but what does this have to do with the amount of time?
Is
this something that you studied?
We did not.
Okay. So why is it a discussion?
Okay.
No, maybe it's important. Maybe you want to bring that up.
Yeah.
But if you want to bring it up, you have to talk about it someplace in methods and results. Otherwise, you just can't bring it out of the sky, something out of the sky, and discuss it. That's not the goal of a discussion.
Yes.
Once again, the goal of a discussion is to report how your results, how your methodology compares to what other people have done. Okay?
Okay.
If it's something that you want to point out, it may be. Then you have to put it in methods and you have to put it in results. Then you can discuss it.
Yes.
Okay? Once again, I'm talking about the bowl and not the fish.
Okay.
Okay. I think I don't want to prolong torture any longer. I think we have an idea now of what critical appraisal is.
Okay.
Dissecting practically sentence by sentence every statement and finding out what essentially the meaning that we want to give to each phrase, each sentence, I'm sorry. So my recommendation, once again, is that medical writing, especially the discussion, as Professor Boni mentioned before, should not be done alone in a dark room between 3 and 4 o'clock in the morning by yourself, okay? It's a group discussion. Your co-authors have to participate in the paper that you're running. This is their role. 1 or 2 people are responsible for the referencing, 1 or 2 people are responsible for the data collection, 1 or 2 people. Everybody should be involved in the discussion.